coveted slot.
All right, Ashlyn Everett, UAB, IROC-XRT, an Introductory Radiation Oncology Curriculum for non-radiation oncology trainees.
So this may feel like deja vu because it's very, very similar to Tukimo's project, which is exciting, and I think exactly what this is about. It's about collaboration between institutions and sharing ideas and making all ROECs better. So this is a project that stemmed off of the IROC curriculum, which hopefully a lot of your institutions are involved with, and we'll hear an update from them this afternoon. But after participating last year, I felt like it was a great platform to use to educate our colleagues in other non-radiation oncology specialties about what we do. Like Tukimo said, it's a black box and not everyone knows what's going on. So this is my roadmap. We have talked about a needs assessment that was presented last year by Nikita Padel, who cannot be here today. I'm going to present to you our curriculum and then some future plans, and hopefully start our recruitment process for anyone that might be interested in participating with us. So that's our roadmap, and I know everybody's come from lots of different places to Chicago today, so I'm excited to get to talk with everyone. So my black box is a pile of pennies. If I had a pile of pennies for every time I explain that I'm not a radiologist, I'm a radiation oncologist, and it's not the same thing, I think I could make a floor that looked like that in my bathroom, which would be kind of cool. But not only outside of the specialty of medicine, but even within medicine, people don't understand what we do and how it's different than radiology, and that we're not just sitting in a black room reading our scans, but we're designing and planning treatments. And there's been a lot of data that's been published that shows that people don't have exposure to radiation oncology during medical school, and it's very important that we work on that, which I'm excited to hear about a lot of the talks later on today. And there's a lot of data that also shows that multidisciplinary care improves our patient outcomes and improves their quality of life, and it improves their mental health and decreases utilization of resources. So our patient outcomes are really dependent upon us working well with our colleagues in coordinating care in the field of oncology, as well as with our other non-oncology subspecialists. So the IROC curriculum you'll hear about later, if you don't know about it, is a kind of introductory for PGY2 residents that are starting in radiation oncology training to give them basic skills that get them implemented, that get them oriented to the clinic quicker. It's 7 sessions. They had 40 programs participating with 90 residents last year, and hopefully we'll hear a little bit more detail later on today. But I thought that was a really nice platform to use to develop a non-radiation oncologist curriculum. And Dan Golden gave us the wonderful idea of calling it IROC-XRT so that they knew it was radiation, since that's oftentimes how we abbreviate radiation, and kind of associate it with the platform that was the inspiration. So I tried to print some handouts. I know I do not have enough, so I apologize, and I'm happy to share the slides with anybody. But the components that we wanted to bring in were the teacher needed to be either a faculty or maybe an upper level chief resident that, like Aaron mentioned, would be someone that maybe knew the people in either internal medicine or radiation or medical oncology or any of the other subspecialties that we work with. We wanted to have some sort of pre and post assessment that we could implement to evaluate how well our educational curriculum was working. We wanted to talk about toxicity and the newer modalities, because those were 2 of the big things that Natika's needs assessment was focused on last year. And then we wanted to certainly talk about our radiation oncology workflow, because like Tukimo mentioned, no one knows how long it takes. They expect that they can get treatment the same day or maybe the next day when it's SRS, and you can't do that. Or they don't understand that a little bit of radiation isn't really something that we do unless it's intended upon it being in palliative treatment. So these are just some examples of some of the slides that are in the curriculum that I've handed out. I wanted to talk about how you shape the beam and what an MLC is, and that's how we use IMRT to create specialized treatment fields, and that the MLCs can move and project different fluence patterns, but that's not the word I'm going to use when I give this lecture. I also wanted to talk about the timeline, and so this was the graphic that we created. And generally, for patients that are coming in for outpatient treatment, the time from their consultation to starting treatments is on the order of a week or 2, not days and not hours. But that changes obviously with palliative treatment. So we have a slide about why is this taking so long. Radiation planning is, of course, patient-specific. We want it to be precise and accurate. It involves a big team of people, which we've talked about in a previous slide, and coordinating with other specialists. So a standard plan is going to take a few weeks, and then in an emergent case, we can accelerate that to 24 to 48 hours. We also thought it was really important to kind of establish who can and who cannot have radiation therapy. A patient that's really not going to be able to cooperate or is going to be in too much pain to lay still for treatment is not a great patient to bring down because they're lifted up on the table 3 feet in the air. And a lot of people don't even know that our tables move and that they're going to be lifted up in the air for potentially more feet. So that is a danger to the patient if they're not able to cooperate. We do have a lot of pictures of simulations as well as, will this work? This is a video. I have a video of just how we can contour. So I'm contouring the spinal cord, and you can see that we kind of use a pencil, and I wanted to show them that you can use a brush, and you all don't need to see how to contour because you're the experts. And then I also have a slide about the different modalities and how they're different, as well as a slide for how we deliver treatment. So this is a BMAP plan on a head and neck patient, and it shows how the MLCs move around, and I wanted to demonstrate that obviously radiation is not going through the MLCs, so only a little bit is getting through when it rotates around the patient, and that is the principle of BMAP. Like we talked about before, we wanted to address radiation toxicity, so I went through some of the very commonly treated sites and some of their toxicity, as well as the timeline in which toxicity develops in our patients, because it's not immediate, it's usually delayed a couple of weeks and then resolves, and then late toxicity starts after treatment, so they have different timelines. And then this is one of Dr. Field's slides about radiation emergencies, and we have some slides in to talk to the medicine residents as well as the medical oncology fellows about when you call us and what we consider emergencies, and some key elements to communicate with a radiation oncologist. And I don't know if anyone else in the room that's a resident has experienced this, but come July, when our new interns start, I feel like I always have to tell them, I need you to stop. Do they have cancer? Like, I don't want their full HPI. Let me hear if they have cancer and what stage they have. So telling them like how to talk with us, I think, is a really key thing to save them time as well as me, and make everyone happy at the end of the day. So our next steps, we are hoping to pilot this curriculum at a couple of institutions this year for our medical oncology fellows, and then I think a next logical step would be to move into the internal medicine realm, and then hopefully in a similar model to how we've done IROC is to expand it to any interested institutions, and then develop and implement curricula for other specialties, because I think that this is very applicable to our gynecology oncologists, our ENT, to neurosurgeons, potentially to dentistry, all the people that we work with on a regular basis that may not have any exposure to radiation oncology. And I love the chemo's idea of having the palliative fellows or potentially any of those fellows or residents come in for a 1-week exposure to radiation oncology where they can see the way that we treat our patients. So I have a Google form, but you definitely use the QR form if you're interested in participating with us. I would love to get in touch with you and put you down on our list. And I will come back to this slide, but so in conclusion, we obviously have the problem that a lot of our colleagues are not very familiar with radiation oncology. We're trying to develop a standardized curriculum to address this problem, hopefully pilot this year at 4 to 5 institutions, and end up with improved patient care at the end of the day. So I do want to thank Dr. Fields and Dr. Jimenez, who've been mentors, as well as Nitika, who did the needs assessment, and we all have worked together to create the slides that you have in your handout, and I will take any questions.